metastatic urothelial carcinoma is still, unfortunately, for nearly all patients, still a life-threatening disease, a survival-defining disease. Although patients who benefit from immunotherapy, patients who respond, the duration of that response is generally quite long, most of them still relapse, and so there's still a need for therapies after completion of immunotherapy. And of course, there's still a large group of patients who don't respond to chemotherapy, and an even larger group who don't respond to immunotherapy. So there's still a high unmet need. The good news is there are already treatments coming through in that post-chemo, post-immunotherapy setting. We've already seen positive survival data for enfortumab vedotin. That's a drug which has marketing authorization in Europe. It's not widely available yet in the UK, hasn't been reimbursed yet. And we're seeing other drugs like sacituzumab govitecan, another antibody drug conjugate, coming through. I think the other area that's still really important, of course, it's what we set out to try and address with the Atlantis trial, is actually, are we doing the right thing by treating all the patients the same? Where's the concept of precision medicine in urothelial cancer? Apart from some, in my view, rather marginal claims about PD-L1 status, we don't really have any molecular predictors in current use. Now, obviously, there are fibroblast growth factor receptor inhibitors, which have marketing authorization in North America, not yet in Europe. Of course, we're still waiting for results of phase 3 trials there. So that's for patients with genetic aberrations, somatic genetic aberrations in the fibroblast growth factor receptor pathway. So we really do need to try and identify patients who maybe are not going to benefit from conventional approaches and might be better off with targeted approaches, and to try and really understand the heterogeneity of the population better.